So the case presentation talk about a 75 years old female that was admitted into the emergency department due to acute chest pain and dyspnea. There was no history of cardiovascular risk factors, prior heart disease, or trauma, and the patient was otherwise in good health. On physical examination, jugular ingurgitation and bilateral rales in pulmonary files were identified. Heart sounds were arrhythmic and tachycardic, without murmurs. Other vital signs showed hypotension and tachypnea. An electrocardiogram was performed, and I want you to take a look of this electrocardiogram because the first question will be related to it. What does the electrocardiogram shows? A, we have a ventricular tachycardia, atrial fibrillation with a non-ST segment elevation myocardial infarction, atrioventricular block, or atrial tachycardia with ST segment depression. I will go back to the electrocardiogram and give you a few seconds to think about it. The suggestion was atrial tachycardia with ST depression, or ventricular tachycardia with ST depression, or atrial fibrillation with the non-ST depression wave. And then we have also atrioventricular block, third degree. So take a few seconds and try to write your answer on comments. Feel free to answer. We are all here to learn. Okay? I have here two persons who give their answers, atrial fibrillation, and we have C, okay? The other one, do you want me to go back to the suggestion or keep the electrocardiogram? Okay, I will go back to the suggestion. We have ventricular tachycardia for A, B, atrial fibrillation with non-ST segment elevation myocardial infarction. For C, we have atrioventricular block, the third degree with ST segment depression, or atrial tachycardia with ST segment depression. Okay, another few seconds. Okay. So we will move to the answer. So the answer is an atrial fibrillation with non-ST segment elevation myocardial infarction, the non-STEMI. It's the correct answer, it's B. Here, as you can see, we have the P wave of the atrial fibrillation, and we have here the depression of ST in V5 and V6 that shows the non-STEMI myocardial infarction. In this slide, I put an easy way to remember the atrial fibrillation when you are against an electrocardiogram, okay? And you see an irregular rhythm, which means that the space between the are not equal, not the same. As you can see here, it's not equal. And we have a fine QRS wave, which means that it's low than 0.12. We must first think of an atrial fibrillation. So to take notes, it's very important and easy to remember. Irregular rhythms plus fine QRS equal atrial fibrillation until proven otherwise. You can take picture of it. It's an easy way to remember the atrial fibrillation. A chest X-ray depicted cardiomegaly, left and right atrial enlargement, and sign of pulmonary congestion, and troponin was 0.058. Which scoring system was used for risk stratification in this patient? Schatz-Fask, Gray score, Geneva score, or Hart score? We used a system of risk stratification score. Which one? Schatz-Fask, Gray score, Geneva, or Hart score? We have two here that mention A. The answer A. What about the others? Okay. Geneva score. One say C. Okay, we have C here. The other one says C. I will wait for more seconds for the other so they can write their answer on comments. Okay, other 3 seconds, and we will move to see the correct answer. So the correct answer, it's B. It's a Gray score. Why? The GRACE score, which means Global Registry of Acute Coronary Events, is specifically designed for risk stratification in patients with acute coronary syndrome. If you remember, our patient have an non-STEMI, including both ST segment elevation myocardial infarction or the non-ST segment elevation myocardial infarction. Why we didn't mention the other? For the Schatz-Fask score, the scoring system it's of course commonly used to assess the stroke risk in patient. However, it's not typically used for risk stratification in acute coronary syndrome patient like the one described in the case. For Geneva score, we use it to the pulmonary embolism, which is not the case. For the heart score, is primarily, of course, used for risk stratification in patient presenting with chest pain to the emergency department. This image shows us here that the GRACE score integrates this clinical and laboratory parameter to estimate the risk of in-hospital and long-term mortality in acute coronary syndrome patient. The risk stratification scales were calculated, obtaining 189 points in the GRACE score. Now we will move to the other question. The third question is, what is the initial treatment to be administered? Enoxaparin, aspirin, clopidogrel, or lanatozid C? I will wait for your answer on your comments. Uh, I just see here uncommon Geneva is for. Yes, we usually use it in pulmonary embolism. Question 3, A, B. We have a person that mentioned A, B, C. Okay, the other. Okay, we have C. A, B, C. Okay, the other one. Okay, the other A, D, A, B. Good. We will wait for other 5 seconds or maybe 6 seconds to move to see which is the correct answer. Okay, so the correct answer, all of the above, enoxaparin, aspirin, clopidogrel, but also, yes, lanatozid, also D. Initial management include double antiplatelets therapy with aspirin and clopidogrel and anticoagulation with enoxaparin. Most of you answer that correctly, but what you forget that we have in this case an atrial fibrillation, and the atrial fibrillation reverted with the administration of lanatozid C. Lanatozid C, it's like a digoxin, so it slows down the rhythm and slow down the atrial fibrillation. Sorry. So all of them. Correct answer are A, B, C, and D. The patient was initially managed as non-STEMI, and an urgent coronary angiography was performed in order to discard coronary artery occlusion. Here we have the coronary angiography. So the question is, question number 4, what abnormal finding was observed in the coronary angiography? A, abnormal neovascularization, aneurysm, coronary artery dissection, or a calcification. Sorry, the image, it's not a good quality, with not good quality, because I tried to put the question next to the image to facilitate to you and to make it easy. Okay, we have Iman that say A. Okay, the other one. What about others? To simplify it for you, here the arrow. And here we have the pathology thing. So I make it easy by centrate it like that. So what's the abnormal finding that was observed in the coronary angiography? What about the others? Okay. Another one say A. Okay. Good. Another few seconds. So I think that we will move to, okay, still person right their answer. Okay, we will wait. Mm-hmm. Mm-hmm. We have answer D, A. So the correct answer, most of you answered correctly. The right answer is an abnormal neovascularization. As you can see here, I already centered for you. We have here the left coronary artery, circumflex, ascending coronary, and here we have an abnormal neovascularization that suggests a vascularized mass. Sorry. I put here two different coronary angiography to show you the difference between a normal coronary angiography and a pathology one, which shows a neovascularization. As you can see here, we have the left main coronary, circumflex, the ascending coronary, but it's totally normal without any neovascularization, without any stenosis or something like that. But here we have, as you can see, a neovascularization. Question number 5. What is the next recommended step in the diagnosis evaluation following the finding on coronary angiography? A. Transthoracic echocardiogram and transesophageal echocardiogram, MRI, or a compute tomography angiography. What is the next step? C, other one C, D. What about the others? Okay, we're waiting for the others to write their answer on comments, and then we will show the correct answer. Most of you mentioned answer C. What about the others? So the correct answer for this question, it's A. Why you put C? All of you see in the first step, like we must at the beginning mention the transthoracic echocardiogram and transesophageal echocardiogram for detailed imaging of the cardiac structure, of course. We must go step by step. We used the coronary angiography. We found that we have an abnormal neovascularization, but we must know and we must have a detailed imaging of the cardiac structure. So we will use the transthoracic echocardiogram and the transesophageal echocardiogram in the next step. This image shows a 2D and 3D transthoracic echocardiogram. As you can see here, we have the left atrium, the four chambers of the heart, left atrium, right ventricle, and left ventricle. Also here, the left atrium, left ventricle, and yes, left ventricle and right ventricle, and the sorry, left atrial and left ventricle, and here the right, yes, atrium and the right ventricle. But as you can see here, in this 2D and 3D transthoracic echocardiography, it shows a large echogenic, as you can see here, a large echogenic oval mass that occupies particularly the entire left atrium. You see an oval echogenic mass that occupied particularly all the left atrium. See? Okay. So for the intracardiac mass, just to know about it, an intracardiac mass is an abnormal growth or accumulation of tissue within the chambers or structures of the heart. These masses can include tumor, blood clot, or other abnormal tissue growth. They may cause symptoms such as chest pain, shortness of breath, or irregular heart rhythm. After the echocardiographic finding, the heart team agreed on performing a coronary computed tomography angiography, which showed a non-infiltrative and very vascularized mass attached to the interatrial septum. As you can see here, we have the left atrial and the left ventricle. Here, as you can see, we have the huge mass that occupied all the left atrium. So the next step is that the patient was scheduled for a surgical resection. After we finish our case presentation, I have a random question about the intracardiac mass. Question number 6. What is the most common cardiac mass? Atrial myxoma, thrombus, cardiac metastasis, or lipoma, which is the most common cardiac mass, primary mass. Okay. All of you said B. Here in this question, I forget to add the primary mass, primary benign mass. So pay attention. Sorry, I forget about it. Because that can make your answer different. Okay, good. Good. Yes. Sorry, it's my mistake to not add it. I forget about it. Okay, good. A. Very good. Others, we're waiting for your answer. Write them in comments. I will wait 3 seconds to move to the right answer. Okay, so the right answer, it's the atrial myxoma. Yes, atrial myxoma is the most common primary cardiac tumor, accounting for approximately half of all benign cardiac tumor. Question number 7. Which of the following suggestion is not a benign tumor? Lipoma, fibroadenoma, sarcoma, osteochondroma. Okay, it's an easy one. Okay, others? Good. The answer, it's sarcoma. It's an easy question. All of you answer it correctly. I put here a table that shows the classification of an intracardiac mass with a primary tumor and secondary malignant tumor, the benign tumor, malignant tumor, pseudotumor. You can take a picture if you want it. That englobe all the tumor and classify it. So thank you for your attention. We achieved the end of the presentation. Please take a moment to fill out the Google Forms survey to share your valuable feedback and insights. And then we have just reference.